Good morning. My name is Dr. John Trister, and the topic of today's presentation will be biotensegrity. Tensegrity is a structural system in which tension is continuously transmitted across all of its members. Tensegrity structures are mechanically stable because of the way the entire structure distributes and balance mechanical stress. Tensegrity structures stabilize themselves through the phenomenon which is called pre-stress. The term of tensegrity was coined by American architect Buckminster Fuller. Traditional sculpture design and architectural design was based on the gravity as a stability factors. The Buckminster Fuller and Kenneth Nelson find out that if you distribute forces which require for stability of the architectural design of sculpture among its members, this structure will be able to tolerate not only vertical forces, but also shearing forces. And based on that assumption, Buckminster Fuller, Kenneth Nelson built the structures which were based on their idea. And this is a representation of the idea how tensile forces are spread throughout all structure to maintain stability and strength of the geodesic dome, Buckminster Fuller. This is a sculptural representation of the tensegrity idea of Kenneth Nelson. Artistic representation of the tensegrity by Alexander Rodchenko, Russian artist. In biology, we see examples when the significant stress of the length of the neck and heaviness of the head of the giraffe is able to be tolerated and maintain stability because of equal redistribution of the forces, mechanical forces among the members of the giraffe neck, thoracic, pelvic, and legs areas. Similar see a relationship between mother and child when you see how mother hold the child despite of the significant mechanical stress created by livers to hold the child, the body of the mother maintain stability and strength until some point. Donald Ingber, a physician from Boston Children's Hospital, studied biotensegrity on the cellular level, and he published a beautiful article in the Scientific American Architecture of Life. In this slide, you see the cells, a cell which has cell membrane, cytoskeleton, and microfilament, which in the communication with the nucleus, and actually mechanical forces generated by extracellular space affecting cell membrane through the cytoskeleton will affect nucleus and genetic expression of the desoxyribonucleic acid. Pre-stress is a fundamental feature of the tensegrity. Tissue must be in pre-stress in order to perform their function. Connective tissue is responsible for pre-stress. Connective tissue is an important structural component of the body. Bones, cartilages, capsules of the joints, ligaments which connect the bones, tendons and muscles, fascia, appendages of skin, tunica mucosa and tunica serosa, meninges are all connective tissue and are all present in a various forming all tissue composing organs and body as a whole. Connective tissue made and maintain form of the body and organs composing by its connective cells, tissue, and organs into specific and proper architectural arrangement. I specifically will talk about form versus shape, because shape is two-dimensional and form is a three-dimensional. So it's very important to have a three-dimensional structure in order for normal function of the tensegrity system, specifically pre-stress. One of the examples, as you can see on the slide, you see the pre-stress, you see this ball here, right here, and I will show you with the ball, real ball, and you can see in this situation, the string is relaxed and the ball is not under pre-stress. But in this situation, the string is tightened and the structure of the ball become in a pre-stress. We see this thing we see in a carpal tunnel. When carpal tunnel, you can see this like a bone, and this is flexor retinaculum, and here's a carpal tunnel, and here's a tendons and medial nerve coming. If this is become flat and it's unstable, then during night, the gravitational forces will push the bones against the retinaculum flexorum, causing compressive neuropathy. So the goal in the prolotherapy, when we do prolotherapy for carpal tunnel, how to tighten the system, how to reestablish and rebuild pre-stress, which normally present in the carpal tunnel. Mechanical stresses are critical for control of tissue, form, and function. Mechanoresponsiveness is a fundamental feature of the living system. If your cell membrane, if your tendons, if your muscle will not respond to mechanical forces, then the function will not be normal. The body will not be able to perform function of movement. The body will be unable to perform function of the synthetic function, for instance, liver or pancreas, prostate, name it. Mechanical stress can directly alter many cellular processes, including signal transduction, gene expression, growth, differentiation, and survival. Living organisms are constructed from tiers of system within a system within a system. Limb, arm, legs, they make from bones, cartilages, ligaments, tendons, muscle, blood vessels, and nerves and skin, and all of these structures play different role. For instance, skin has a lot of proprioceptive ending, and as well as tendons and periosteum. And they give information to the central nervous system about position of our limb. And this needs to be presented to the brain, and brain will give feedback in the form how muscles should be working well based on the information getting from the skin. So if skin is damaged or ligamental tissue are not properly working, then brain will be unable to produce normal response to the tissue, how to direct normal locomotions. Organs are constructed from tissue, muscles, fibers, vascular endothelium, connective tissue, which are composed of groups of living cells and their associated extracellular matrix. Mechanosensitivity of the body is related to material properties of its component and to the architectural arrangement of its microstructure. Musculoskeletal system is the integral framework which supports the weight of our body, allow us to rapidly adjust to resist external forces, and permits us to move freely in our environment. Selective pressures demand that the construction of such a machine minimize mass without compromising its structural integrity to handle unexpected forces. Pre-stress and mechanotransduction are the important prerequisites to normal function of the living system. In this slide, I will try to show you the cramping effect on the tissue deformation. Connective tissue, collagen and fibers and tendons, they're in a crimping stage. They're not always tightened. For instance, inferior glenohumeral ligament in a position of adduction of the arm, they're not tightened, they crimped like that. So only when you do abduction of the arm, it's become tightened and go away from crimping. Uncrimping is developed. In the second portion of this slide, you will see prolongation of crimping. So uncrimping is impossible. So stabilization of the ligaments, tightness, normal tightness of ligament is impossible. So, and we see this very often in the cases of ligamental laxity when crimping preclude stabilization of the joint for normal function. This is more professional slide, and you can see graph which depict stress versus strain. And you can see several area of this graph, such as toe region, which shows basically crimping area. This is crimping area where elongation of the ligaments or capsules or tendons is minimal. It just becomes to tighten. And then it's become tightened, and this become like that. And this is linear region of the structure. This is the area when this ligaments start to perform stabilizing function. And it will continue to perform the stabilizing function until it's able to tolerate excessive stress. And here on the top, at some point, it will develop failure of this tissue, specific tissue, to tolerate specific stress. It will lead to plasticity. And on this slide, I'll show you that different structures in our body have a different relationship between load and deformation, load and strain. The bones have one pattern of the mechanics, cartilage another pattern of the mechanics, ligaments and tendons. So the bone is more rigid and less flexible. The cartilage less rigid but more flexible. Ligament can be more flexible and more distendable than cartilage, and the tendons much more flexible in muscle, etc., etc. So in the body, we have not only just two systems like we have on this tensegrity model. We have rubber and we have woods with the two different mechanical properties. We have one mechanical properties for rubber and mechanical properties for wood. In the body, we have myriad of a different tissue with the different mechanical properties. For instance, even bone. One bone in the different areas of the bone will have different mechanical properties. Like epiphysis will have one thing, diaphysis will have another thing, metaphysis will have a third thing. And the same with the tendons and the muscles and the ligaments. In each individual area, the mechanical property will change, will create some cumulative mechanical properties of entire body, cumulative. And this cumulative is summation of the different mechanical properties of different tissue in the structures. What happens sometimes as a result of injury, for instance, of the tendon or attachment of the tendons to the ligaments or to the bone, entire systems start to suffer, but the bones will start to assist each other and try to compensate. And this is called allostasis. So in the first model, you can see here pretty stable structure. This is called icosahedron. And the second, it's a very loose structure, which also icosahedron, but it's built 18 years ago. As a result of different factors, thermal factors, humidity, it's lost its pre-stress. So this structure without pre-stress, and this structure with pre-stress. So the different part of our body will experience a different clinical manifestation as a result of losing pre-stress. For instance, posterior tibialis tenosynovitis, which affect muscular tendinosus junctions of the posterior tibialis on the posterior medial aspect of the leg. The distal end of the posterior tibialis attached to the navicular bone, attached to the cuneiform bones, attached to the ligaments between calcaneocuboidal ligament, calcaneonavicular ligament. In any way, the posterior tibialis control and maintain the arch of the foot together with the ligaments, calcaneocuboidal, calcaneonavicular ligaments. It's very important that arch will be maintained. So we can say that tibialis posterior created tension in the ligaments. In the same time, ligaments assist tibialis posterior to maintain this work. So what happened if for some reason people develop damage or excessive insufficiency in the enthesis, site of attachment of the tendons to the bones, tendons to the ligaments, the amount of stress will be no longer tolerated. So then the entire muscle will respond to this event, and some tissue of the same muscle will be unable to tolerate this. And tenosynovitis is one of the examples. Tenosynovitis, in my opinion, is a consequence of insufficiency in the enthesis. Tenosynovitis is the expression of enthesopathy in the distal attachment of the tibialis posterior, more commonly than in the proximal attachment. Next example is the supraspinatus tendinosis. Supraspinatus muscle in the tendon attached to the humerus, and there's nothing special with this muscle, but often we see the damage of these muscles. And the cause of this problem is the forces which are supposed to be responsible for compensatory reaction in the supraspinatus redistributed and cause the damage of the enthesis or attachment of the tendon to the bone. Certain anatomical factors also play a role, such as the blood flow, instability of the shoulder, laxity of the inferior glenohumeral ligaments, which allow excessive superior translation of the humerus and mechanical damage of the supraspinatus against the acromion. But all of these factors working in a concert. Trochanteric bursitis is expression of enthesopathy of tibial, of the gluteus medius. Whenever we see leg length discrepancy, whenever we see body length discrepancy, these muscles start to work very hard, to bring pelvis in the position of horizontal. Okay, gluteus medius is responsible to elevate the pelvis to the position of parallel, so to satisfy oculocephalic reflex. And when we see patient who comes with enthesis in the gluteus medius, in the trochanteric bursitis, the first thing what we should look in the leg length discrepancy to see which factor led to excessive work of this muscle to keep the pelvis in a balanced position. So gluteus medius enthesopathy is expression of inequality of the length of the body or specific leg. We see this very often in the people with after hip replacements, knee replacements, leg which become longer will develop enthesopathy. Lateral epicondylitis, very similarity. There is an important ligament which connects the radius to the ulna, annual ligament. Laxity of the ulnar ligament will activate supraspinatus muscle, and create a spasm of arcade of Forchet and lead to compressive neuropathy of the superficial branch of the radial nerve. The hamstring enthesopathy very commonly occurs, and we see that both in the proximal and the distal area, pes anserinus in the knee, or pain in the ischial tuberosities in the ischium. Tensegrity structures characterized by use of continuous tension and local compression. Architecture, pre-stress, and triangulation play the most critical role in the mechanical stability of the living systems. Tensegrity network optimize structural efficiency. Mechanical stresses applied at the macro scale result in a structural rearrangement at the cellular and molecular levels. Mechanical stress is concentrated and focused on the signal transduction structures, such as microfilament, integrins, cytoskeleton, extracellular matrix, and nucleus. Biotensegrity is a structural arrangement of the biological systems. It is a self-regulated process utilizing a specific pattern of interactions between members of the biological system to maintain life. Mechanotransduction, biochemical, hormonal, neural, humoral, electromagnetic fields interaction, gravitational force, quantum entanglement, and other known and unknown yet factors are the major mechanisms responsible for cell membrane regulation and transmission of the information to and from the nucleus. This process is modulate gene expression and induce biochemical, neurohormonal, neuroendocrine, emotional, electromagnetic, and other possible responses. Disintegration of tensegrity occurs when stress acting upon the living systems are either very strong or prolonged. When structural components of the living system are weak, or combination of both. These factors lead to dysfunction of the individual members and systems as a whole and lead to loss of pre-stress. Disease is disintegration of biotensegrity. Disease is a loss of pre-stress of the biological systems. Normal pre-stress is a normal function and health. Here I'd like to show you animation from Donald Ingber to show you how extracellular and intracellular environment will affect interaction of the nucleus with microfilament and cytoskeleton. So you see here, you will see that nucleus become oval as a result of changes on the form of the cell. And here, nucleus is pretty round, and the form of the nucleus is different. So it will lead to alteration of the gene expression of the nucleus and production, suppression, or enhanced production of the various of the growth factors, which you can see here on these slides. Mechanical properties of the extracellular matrix will determine synthetic function of the cells. Yes, whatever you have around the cells will affect what will happen inside the cells. With the same growth factors, you can get growth, you can get differentiation, you can get apoptosis, or you can get migration, depending on the mechanical environment of the extracellular matrix. Stiffness of the matrix regulate angiogenesis, the growth, migration, and network formation, tissue development in 3 dimensions. Mechanical properties of the extracellular matrix will determine action of the growth factors. Blood vessels growth stopped if the matrix was too loose, slow it was too stiff, and that optimum capillary network formation occurs somewhere in between. In my clinical experience, I know the tensile forces, the tension, what I did in my work back years ago by elongation of the bone, the tensile forces do stimulate formation of the new growing matrix for the bone, but compression forces actually make it stronger. Tissue cells behave differently depending on the physical characteristic of the matrix to which they adhere and to the physical forces transmitted to individual cells through it. Bones, cartilages, ligaments, tendons, muscles, vessels, nerves, skin respond to tensile stresses by altering their growth pattern. Mechanical signaling goes hand in hand with chemical growth factors produced by the body. In this case, vascular endothelial growth factors. Growth factors are almost always present around the cells, and it is mechanical signals that prime a cells to respond to them or not. The form determines function, the function responsible for form. Bones, cartilages, ligaments, tendons, muscles as a component of tensegrity system. The angulation of the bone, torsion of the bones, twisting of the bone, different angles have a specific purpose because tendons and ligaments working together with this form of bones will enable bones to accept, accumulate, store, and release energy when it's needed. And we see these examples when we sometimes have a bone pain after 3-4 weeks after prolotherapy. This is expression of intraosseous strain, not interosseous, but intraosseous strain. Locomotor contribution to different structures such as stability, movement, energy optimization. Connective tissue insufficiency and aging all play a role. Postural compensatory response. We talk about this briefly. Regulation of the posture and postural imbalance are achieved by proprioception, vestibular system, ocular system, temporomandibular joints, sacroiliac joints, feet, skin. So all of these organs and tissue provide information to the central nervous system for optimal response, how to navigate in an environment, how to function in an environment, how to move in the surrounding. Here, I'd like to talk about allostasis. Allostasis, contrary to homeostasis, is the difference. The homeostasis is a reaction of the body to return to normality, This is like a thermostat. Allostasis is a return of the body to vitality. So if something happened, environmental factors, changes in the weather, mechanical stress, the body will respond. And it will bring us either to normality, homeostasis, or to allostatic response, which not be completely normal, but allow us to continue to function and to be alive. So biological systems must be able to adapt to external and internal stresses. Form and function are indivisible. Form, function, and mechanical properties of the connective tissue determine the purpose of the system. Mechanical properties of the connective tissue, form and function, are influenced by external and internal events. Form, function, and quality of the connective tissue are changing under stresses, and system underwent allostatic responses. Ability to change form, function, and mechanical property of the connective tissue determines success of allostasis. This is a model of the hip joint, and you can see acetabulum and you can see the femur. And surrounding ligaments maintain tensegrity of the structure. In reality, the pelvis is suspended on the hips. There is very little touch of the cartilage to the head of the femur. I'd like to demonstrate this with another device, which is tensegrity structure, tensegrity device like that. And you see this is suspension system, and this is tensegrity. And put a cup on this tensegrity system, and you can see it's very stable and can tolerate the vertical stresses. Successful allostasis is successful change of form, function, and connective tissue, secure vitality of the system. Alteration of the system caused by external and internal events, such as congenital abnormalities, infectious processes, autoimmune reactions, metabolic processes, pharmacological and surgical alteration, various forms of injury, environmental factors, psychological factors will lead to different allostatic responses. The ability of the system to change form, function, quality of the connective tissue will determine the survivability of the system. Allostasis allows the system to return to vitality through the change in form, function, quality of connective tissue. Allostasis begins at birth or even before and after conception and continue through the life of the system. Life is impossible without allostasis. Death is cessation of allostasis response. The system is not uniform in the ability to adapt to change. Rigid parts are less capable of allostatic response but more stable. Flexible parts are less stable but capable of adaptation better than rigid. Entire system participate in allostatic response. All parts of the system contribute to allostatic response with high variability. Elastic energy utilization. During our life and function, we walk, we breathe, we accept, accumulate, and release energy. This is a constant, permanent process. While we're alive, we're able to accumulate, store, and release elastic energy to use for various properties. One of the examples, it will be anterior capsule of the hip. During hyperextension of the hip, the anterior capsule is stretched, such as iliofemoral and pubofemoral ligaments are stretched, and during motion forward, swing stage, this elastic energy release assisting muscles to move leg forward. Respiration, inhalation, exhalation, ligaments which surround the ribs, connection to the ribs to the sternum, connection of the ribs to the spine, is always unwinding of the ligaments, winding of the ligaments, accumulation of the energy, release of energy. This is like perpetuum mobile. It's constantly working together in assisting living. So any changes in the connective tissue, which can change ability to accumulate, store, and release elastic energy, will lead to changes in the function of the entire system. As we get older, our entire system is changed. It's genetically predetermined. It's happened because of various illnesses and diseases. And we have various tissue in the body, skin, ligaments, tendons, and everything. And they all respond differently. And in the model, what you will see now, I will show you icosahedrons, and you will see analogy of this small video with aging process. Hello, this is Tensegrity models, and the model is called icosahedrons. These Tensegrity models are built 18 years ago, and this identical model I built 2 weeks ago. I'd like to show you the difference between two. This is new Tensegrity model which built 2 weeks ago. And this is Tensegrity model built 18 years ago. This is what's the difference. Thank you. Postural imbalance is manifestation of allostasis. In this slide, you will see a young woman with scoliosis and rotoscoliosis, and how her body is adapted to this scoliosis by rotation of the trunk around the pelvis. It's called rotoscoliosis. And you can see the difference in the length of the arms when you measure this. And this is not the difference in the length of the arm, this is consequences of the rotoscoliosis. The gentleman recently come to my office with a right hip pain, and examination, just visual examination, you can see that right shoulder slightly shorter and higher, his left shoulder slightly longer and lower. The spaces on the waist, the different here and here. And if you look from him from above, the picture from above, you see rotoscoliosis. This is all adaptation which develop as a consequences of hip pain. But these consequences, on the other hand, will induce another disease and another problems in the future, maybe thoracic pain or scapular pain. So that's why very important to use postural examination to see how the different clinical condition alter the structure, tensegrity arrangement in the body. Last year I was in the Czech Republic, and we went to the museum and a sanatorium which specialized in the treatment of the musculoskeletal disorder. And you see, and I saw the picture, so in the middle, you see the woman with positive Trendelenburg sign and scoliosis. I thought it's very interesting. The foot have several arches. It have longitudinal arches on the medial aspect. We have a longitudinal arch on the lateral aspect, and then we have several arches, as transfer arches in the forefoot, in the metatarsal area, and the tarsal area. And the form of the foot will change every time when we walk, or even during swing stage. The form of the foot is different, and it's prepared for next stages of the locomotion. So the change in the form is very different in the foot. So ability of the foot to change the form is representation of the quality of the connective tissue of the foot. So if people have laxity of the ligaments, which in the area of the metatarsophalangeal joint or in the area of the metatarsal arch and the tarsal arch, it will affect function of the foot and function of entire organism. I had several emails to demonstrate how to do prolotherapy on the foot, and I'd like to share this with you. Okay, we'll start injection of the foot. So first will be local anesthesia. I will inject medial aspect of the foot. So I identify the navicular bone, it's right here, navicular bone right here. and there is a small hole, and behind will be sustentaculum tali, which is the talocalcaneal joint. So I will inject around the sustentaculum tali, number one. Then I inject the space between sustentaculum tali and navicular bone right here. Right here. This is above will be thallus. And I keep the foot in a 90 degrees of flexion, and I will infiltrate the lidocaine toward the calcaneocuboidal joint from inside. So this is also point of injection to the navicular bone, site of attachment of the posterior tibialis and spring ligament right here on this side. Then I will go into spaces between metatarsal bones, between first and second, one, between second and third. This is still local anesthesia. And fourth and fifth. Then I will inject local anesthetic into the area of the sinus tarsi, which is a subtalar joint right here. Distal tibiofibular junction or anterior tibiofibular ligament. And then from here, it will be point of injection into distal syndesmosis, which is space between fibula and tibia here. Stop and do. We'll start to do right now injection of the calcaneocuboidal ligaments. Okay, we'll go from here, and I advance needle slowly, 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 until I reach the point of the calcaneal and cuboidal, and I inject about 1 cc or 15% of dextrose. Then I slightly pull needle back and change the angle, and again advance needle forward to inject here. So the whole arch of the joint will be injected. So this is mid-tarsal joint. Then from the same place, I will inject over the navicular bone, right here, navicular bone, with the site of attachment of the spring ligament and posterior tibialis. You see, I change the angle to address the issue to entire space between sustentaculum tali and navicular bone. And I go around, changing the position. Now I'm on the calcaneal bone, okay, sustentaculum tali from the calcaneal bone. Okay, so this is on the calcaneal sides. They will be very deep. So by doing this injection, I inject basically all medial aspect, spring ligament, calcaneocuboidal ligament, and talonavicular ligament. Now we'll try to inject the spaces which correspond to Lisfranc joints. So this will be spaces between first metatarsal and second metatarsal and third metatarsal and fourth metatarsal, but from the dorsal aspect of the foot. So this is what I'm going to do. I'm going to space between them, and I inject this here. And I walk my needle a little bit one direction and another direction, and I inject. Okay, the solution certainly will go slightly down in the plantar aspect as well, where the site of attachment of the peroneus longus here, okay, tibialis anterior, and partially tibialis posterior as well, send the fibers to the basis of the metatarsal bones. Okay, so I'll go again, spaces between metatarsals, spaces between metatarsal on the border with the cuneiform bones, okay, cuneiform bones. So on the lateral aspect, we injected there. Now I changed the needle, and now my next point of injection will be short peroneus brevis. Now we just injected the sinus tarsi, and from sinus tarsi I move needle toward the fibula and tibia. So this is distal connection, distal junction between tibia and fibula, and this is correspond anterior tibio-femoral ligament. But in addition, I will inject directly into fibula, then space between fibula and tibia, and tibia. And I go a little bit more proximally and again inject fibula, space between fibula and tibia, and tibia. Again, fibula, space between them, and tibia. Then again, fibula, space between them, and tibia. The needle always touch the bone, always touch the bone, always touch the emphasis. The last injection will be injection into the distal syndesmosis. So distal syndesmosis is like a ford between fibula and tibia. So my needle will go into the space between them. So I palpate the fibula, and this is tibia, and my needle goes very tangentially toward this junction. And I'm right now on the junction, okay? And I submit several injections into this area to stabilize the distal syndesmosis. This is exactly where syndesmosis. Here is a tibio-fibular ligament, but syndesmosis will be here. All right, that's it. Now I'd like to demonstrate you one case, interesting dramatic case of the woman, a 58 years old woman who was diagnosed with idiopathic scoliosis at the age of 13 during puberty. Scoliosis was very minor and didn't require any surgical treatment. She was treated by physical therapists, massaging and exercises. She did well during puberty. Her scoliosis did not progress significantly, and she married, and during pregnancy, her scoliosis did not progress as well. She did very well during pregnancy, delivered a baby, a girl, everything was fine. By age of 35, she developed bilateral hallux valgus, and she was unhappy with cosmetic appearance of this hallux valgus. Functionally, she was fine, and she decided to have a surgery. So she went to a local podiatrist, and a surgical procedure was done. And she was not happy with the results, and because of pain, and she had a second procedure. And after second procedure, I have a film which shows the excellent result of the osteotomy and the proximal first metatarsal, but clinical results was not such a great. She had the pain, she had difficulty walking, and she decided not to do right foot after that unsuccessful left foot surgery. So she came to me 2 years ago, and examination revealed a very skinny woman with multiple problems. And what was found on the feet, that left foot, operated foot, had very flat arch, and the right foot had the normal arch like she had before. She had the hallux valgus on both now, but in addition, she had the flat foot on the left and the normal arch on the right. And she had a multiple problem with the back. After surgery on the foot, 2 years later, she developed pain in the back. The pain progressed, didn't respond to conservative treatment, and eventually patient had the surgical procedure, 1, surgical procedure 2. Eventually she had 8 surgical procedures. And this is what she had during 8 years after unsuccessful surgery on the hallux valgus. Total hip replacement, stabilization of the lumbosacral area, stabilization of the spine, stabilization of the neck. She is on multiple medications for pain. In my opinion, the major cause of this is iatrogenic leg length discrepancy, which develop as a consequences of the unsuccessful surgery on the left foot with the result of flat foot and exaggeration of the leg length discrepancy and progression of the scoliosis are the consequences of this fact, which led to all of the things. Certainly, I couldn't help her with prolotherapy. I just continued to give her prescriptions. She died accidentally from drug overdose. This is a slide which shows how body will react to fourth nerve palsy. And as you can see, it will lead to significant postural imbalances in the body. And the clinical manifestation could occur in any place of the body. And this will be determined by previous problem in the area. For instance, someone had knee pain in the past during teenager age playing tennis, developed twisting of the leg, nothing happened, and then later developed problem with the eye, and this area which was healed before with the knee may start to ask for help. This is another example of the pathology and the consequences of the pathology, and you can see rotoscoliosis, which develop as a consequences of the surgical intervention. I hope I was able to deliver to you importance of the tensegrity model, understanding biotensegrity, understanding of the pre-stress, understanding of the mechanical properties of the connective tissue and allostatic response. Thank you very much for your attention and have a good day.